Hello everyone and welcome back to my channel. In today's video we're going to talk about diuretics. So diuretics are very important in clinical practice, not just for anesthesia providers, because of various reasons that we're going to talk about in this video. So we're going to start by the classification, the site of action, mechanism of action, the treatment, the complication, and the special consideration. For the purpose of this video, I'm not going to dive into the deepest of each diuretic. We're going to talk about the base of them and have a general idea. So before we get started, I'm going to draw a picture of the nephrons. It's going to help us understand where all these different drugs are going to, their site of action. So I'm going to do my best. So here is a picture of the nephron. Here is going to be our glomerulus with our afferent and our efferent arterial. This is going to be our proximal contour tube. This is going to be the ends of Henle, the thick descending loop of Henle, and here the thick ascending loop of Henle. This is going to be the distal tube, contour tube, and this is going to be the collecting duct right here. And our urine is going to come here. This is the lumen in here. So I'm also going to add the proportion of sodium in different portions. So here, normally 25% of the sodium get reabsorbed into the thick ascending loop of Henle. And on the distal contour tube here, we have 5 to 10% reabsorption of sodium. And on the collecting duct, we have only 2 to 3% of the sodium normally reabsorbed. So let's talk about the first diuretic we're going to talk about. It's going to be the carbonic anhydrase inhibitors. Carbonic anhydrase inhibitor, and our protective drug here is gonna be acetazolamide. So acetazolamide is going to act on the proximal contour tube here. So carbonic anhydrase inhibitors. So the site of action, once you give acetazolamide, it gets into your blood, then it gets into your kidney. It's going to act on your proximal contour tube here, and it's going to inhibit the carbonic anhydrase enzyme in the kidneys. And what does that enzyme do? So you have this reaction, CO2 plus water is a reversible reaction that the carbonic anhydrase is going to catalyze, giving you your H2CO3. And this H2CO3 is going to get split into your bicarb, HCO minus plus your hydrogen ion. So when the acetazolamide inhibit this enzyme, you have less formation on your bicarb, and also it's going to empower your bicarb to get flushed out in your urine. So it's a diuretic that mostly eliminate the bicarb, and also the bicarb is going to come out along with your water, with your sodium, and with your potassium. So you're going to have a decrease in all these ions. This is the main mechanism of action of carbonic anhydrase. So why do we use that in clinical practice? Is a diuretic. We're going to use that in the situation of increased ICP, although it's not a drug of choice, but it's going to do the same action. It's going to deplete your water and your bicarb. decrease your vascular fluid amount and also decrease your ICP. So we're going to use that to decrease the ICP. Also, we're going to use this drug for sickness, the mountain sickness disease. Mountain sickness disease. This is like when you're getting high altitude up in the mountain, you have a decrease in your O2 amount. Your oxygen get less compared to the sea level. And what your body is going to react with is going to try to hyperventilate to get more of that oxygen. And that hyperventilation is going to create respiratory alkalosis, right? And because acetazolamide is going to increase your respiratory drive, you can also give it orally, by the way. It's going to increase your respiratory drive. It's going to increase your PO2. Acetazolamide is going to increase your O2. So that's why we give it in mountain sickness disease. Also, we give it in state of epilepsy for the same reason, in the state of seizures, because of that increase in respiratory drive and PO2 that you can have. Acetazolamide can also be given in COPD patient, chronic COPD. But this is going to be an edge with two swords, because in COPD, you have a good compliance of the lung. These patients are going to retain the CO2, be in respiratory acidosis, and they're going to compensate on the long term with metabolic alkalosis. So because acetazolamide is going to give you metabolic acidosis, it's going to try to match the metabolic alkalosis that chronic COPD have as a compensatory mechanism. But it's also going to be bad with those patients in COPD, because with acetazolamide, you're losing all your bicarb and you don't give them that buffer to compensate for their respiratory acidosis. So be very cautious with the patient with COPD. Now, one of the adverse effect complication of acetazolamide, and this is going to be the reason why we don't give it so often in clinical practice, because if you remember your anion gap is your sodium minus your bicarb here plus your chloride. And your ion gap is your electroneutrality. Normally it's supposed to be 10 plus minus 2. Now, if you have this huge loss of your bicarb, because with acetazolamide you lose more bicarb than anything else, the body is going to try to retain the chloride to maintain that electroneutrality, and it's also going to retain the H plus along to maintain it, the electroneutrality. So because of all this retention of the chloride and the hydrogen, you're going to have a metabolic acidosis. Metabolic acidosis. That metabolic acidosis is the reason why we don't give acetazolamide like very frequently in clinical practice. And also, because you're losing this huge amount of bicarb, this bicarb is going to get into your urine, and it's also going to alkalinize your urine. Sorry guys, alkalines your urine. So if your urine get alkalinizated, it's not a good thing for anesthesia provider, because most of the drugs you give are going to be weak bases. Your local anesthetic, they are going to be weak bases. Once you give them, you also want them to be excreted into your kidney. You want the patient free of drugs. So because of this alkalinization, weak bases work better in an alkaline environment. They are not going to be excreted. Instead, they're going to be reabsorbed into your body, and your patient is going to have this lingering of the drug. So you want to be careful because of the metabolic acidosis and the alkalization of the urine. We don't give acetazolamide like very frequent in the current practice. And acetazolamide is also going to decrease your intraocular pressure, although it's not the drug of choice. But this is what I got for acetazolamide. So I'm going to move to the next. Like I said before, this is not going to be deep. I'm just doing this video to compare all the different diuretics that we have. So the next diuretic we're going to talk about is going to be the osmotic diuretic. The osmotic diuretic, they're going to act a little bit everywhere, but mainly on your thick descending loop of Henle here. You're going to have your osmotic. And a little portion is also going to act here on your proximal quantum tube. And then very weak portion is going to act here on your distal tube. So distal tube here, I'm going to put osmotic. So the prototype of our osmotic diuretic is going to be mannitol. So when you give mannitol to your patient, mannitol is going to get into the blood and then eventually get into the kidney for its site of action, and it's going to get into the kidney through glomerular filtration. So meaning that if you have a patient that have a low GFR, maybe in kidney disease, you really want to adjust the dose of mannitol. And how the mannitol going to act? Mannitol is going to act with the osmotic pressure, the oncotic pressure. I uploaded a video about this hydrostatic versus oncotic pressure. If you haven't watched that, I highly suggest that you watch it. But it's a big molecule that is going to pull the water into the vascular space, and that is the main action. So it's going to pull the water inside here. So it's going to increase the osmolarity of your plasma. Is going to increase your osmolarity of your glomerular filtrate, and that's how the water is going to follow. The water is going to go from the space less concentrate to the more concentrate. So this is how you're going to get your water flush. So with mannitol, unlike acetazolamide, you're going to get more water flush out, and you're also going to get your electrolyte imbalances. Now, with mannitol, we're going to have a watery diuresis. And how this is going to happen? So mannitol is going to decrease the viscosity of the blood, because it's going to move, because it's such a big molecule. It's act like albumin. So the fluids are going to move from the intracellular space to the extracellular space. Remember, mannitol act like albumin. So, and we have more fluid inside our intracellular space. So when that fluid moves from the intracellular space to the extracellular space, we have a decrease in the blood viscosity. And because we have a decrease in the blood viscosity, we have a decrease in our RAS system. Because renin gets activated when it senses a high sodium or a high viscosity. So we're going to have a decrease in our renin-angiotensin system. We're going to have a decrease in the vasoconstriction in our renal artery. And this is going to increase the renal blood flow. And once the renal blood flow is going to be increased, we're going to have increase in the excretion of sodium, chloride, and urea. Why am I talking about these three molecules? Because these three molecules are responsible in the medulla portion of the nephron for the concentration of the urine. So if we are depriving that part of the nephron from this molecule, this part is not going to be able to concentrate our urine anymore, and that's how we get the watery diuresis. Now, I said with mannitol, we're going to have more water coming out than anything else. That means you can have a hypernatremia, but in other cases, you can have hyponatremia with mannitol. Like if you administer mannitol too fast and you have this fluid going from the intracellular space to the extracellular space too fast, that fluid is going to come out along with the sodium, with the potassium. And because we're going to have a high amount of potassium extracellularly, we're going to have exchange of potassium with the hydrogen ion, which is going to give us a state of metabolic acidosis. So it's going to give us a state of metabolic acidosis, and because of all the fluid here, we're going to have dilutional hyponatremia. And this is how you don't ever want to administer mannitol too fast. And also in your brain, before you administer mannitol, you want to make sure that your blood-brain barrier is intact. Because think about it, mannitol is so big, and if your blood-brain barrier is not intact, in your cerebral space, it's going to pull out that fluid. And that fluid is going to pull out, but you're going to have a rebound in that fluid because of the deficit. More fluid is going to come back to it. So it's going to increase your cerebral edema. So you're going to have an increase in your cerebral edema, rebound, and increase in your ICP. So never administer mannitol too fast. And also, concerning about the special consideration of mannitol crystallizes. So you always want to use a filter, especially for the 20% or 25%. And it crystallizes even more in a cool environment like the OR. So you always want to make sure that your bottle is warm and that you are using a filter. So why do I administer mannitol? It's a drug of choice of decreasing your ICP. Is very used in trauma patients with all the ICP. It helps decrease your ICP. It's also going to help decrease your intraocular pressure. Now, we also have to be careful for the patient who has congestive heart failure because of all the shift of water from the intracellular space to the extracellular space. The heart might not be able to pump out all that huge amount of increase in preload. So you really want to make sure that you watch the left ventricular ejection fraction of your patient. And if they are not able to pump that, you're going to have that backup of water into your lung, giving you pulmonary edema. So just be aware. So mannitol is a great drug, but we just have to be cautious while giving mannitol. And also, mannitol is going to give you hypokalemia. So you want to watch for your dysrhythmia, you want to watch for your cramps, all the good stuff. So this is what mannitol is going to do. So make sure you adjust your renal dose. If your patient has renal failure, make sure you adjust the dose of mannitol. Now we're going to move to the next one. And then we're going to talk about the loops. And here, this is going to be our loop diuretic. So the loop diuretic are the second most potent diuretic apart from the mannitol. They are very potent because look where they act. They act where 25% of sodium can be reabsorbed. And this is huge amount of sodium, and water follows sodium, so they really gonna be potent. And another part of their potency comes from the fact that after this thick ascending length of Henle, the rest of the portion of the nephron doesn't have that capacity and capability to really absorb sodium. So this is why the loop diuretic are very potent. And the loop diuretic, we can classify them from the most potent to the least potent. So we have bumetanide, which is going to be more potent than torsemide. Torsemide is going to be more potent than furosemide. And furosemide is going to be more potent than ethanic acid. So this is the order of their potency. Ethanic acid is not really given because it's very expensive, and it gives you like auto nephrotoxicity that we're going to talk about shortly. It's usually used like when a patient have a sulfur allergy. So this is why we don't really hear about it. So the site of entrance, how the loop diuretic gonna enter, they're gonna be secreted into the tubules. So they're gonna be secreted inside here, and a little portion is gonna be in here, the glomerulus, just a little portion. And this is the reason why loop diuretic can work if you have a decrease in your glomerular filtration rate, because look where they access the kidney, into the tubular secretion. So they don't really rely on the glomerular filtration to get to their site of action. And this is very particular to them. So what is the mechanism of action? They're going to inhibit the pump and chloride. So they're going to inhibit this pump, and they're going to flush most of this iron. We're going to have decrease in sodium, decrease in potassium, decrease in magnesium, decrease in chloride, decrease in calcium. So all these decrease of ions are going to give you like cramps. You're going to have cramps in your extremities and also in your GI. And you're also going to have nephrotoxicity. So you're going to have toxicity of the ears that is reversible, and toxicity of your kidney, especially when you give them along with your aminoglycoside and vancomycin. You can have this nephrotoxicity. Also, loop diuretic are they bind to protein very much. So their protein binding fraction is really high. And other drugs that also bind to those proteins, they are going to compete together on the binding side. So drug like warfarin binds highly to protein. So because loop diuretic are going to compete, they're going to remove the warfarin from those proteins. So the warfarin is going to be found unbound in the blood. And the unbound fraction is the more active fraction. So you're going to have increase in your risk of bleeding. Increase your INR and increase in your bleeding risk. So watch out for that. The depletion of potassium too can give you arrhythmia. And also it's very important in anesthesia because you have your neuromuscular blockers like cistracuronium, rocuronium. Now the decrease in potassium and also the decrease in acetylcholine release that they're gonna induce is gonna like empower your effect of neuromuscular blocker. Think about it. If you don't have acetylcholine is a neurotransmitter that is gonna act on the nicotinic receptor and give you the muscle contraction. Now, if given lazy chronically, is going to reduce your secretion of acetylcholine. You are already in this state of less muscle tone. Now you're adding your neuromuscular blocker, so it's going to have a synergic action and it's going to increase their toxicity. Now, after you administer, let's say you have a case, you gave your neuromuscular blocker, and after you administer them, you want to reverse those neuromuscular blocker, you're going to use neostigmine. Neostigmine is the reversal of your neuromuscular blockers, and it's also an acetylcholinesterase inhibitor because it inhibits the enzyme that is responsible of the breaking down of acetylcholine. So now it's going to increase the amount of acetylcholine in your body and restore your muscle tone. So if you need more of the neostigmine, so you are also at increased risk of the neostigmine during your case, and you are at increase of the toxicity. So with the chronic administration of the loop diuretic, you want to watch out for these things when you are having a case. It's very important. Now also the loop diuretics are also going to have a direct vasodilation on your vein. So they are direct vasodilator. They're going to dilate your vein and decrease your preload. They're also going to increase the secretion of prostaglandin. Prostaglandin are responsible of your vasodilation in your kidney, and they also help flushing out your sodium. They have a natriuretic function. So this is the loop are going to have a direct increase in the production of the prostaglandin, and that's why they don't work with the NSAID, because the NSAID inhibit the production of your prostaglandin. So you don't want to give them together. Loop can be used in the treatment of hypertension, all type of edema, and usually the hypertension is because of this preload reducer. You can use them in adjunct with other drugs, and you can also use the loop with the thiazide diuretic. We're going to talk about them because they also going to help with the diuresis. You can use the loop to decrease your ICP with other drugs. So loops are very widely used, and like I said, you want to watch out for your decrease in calcium, your decrease in electrolyte, and this is what I got for the loop. So let's move on the next. So now we're going to talk about the thiazide diuretic. Thiazide, they add here. So thiazide diuretic, and the main one that you're gonna give, because it's the only IV, is gonna be chlorothiazide. So the thiazide diuretic, the site of entrance, they're mostly gonna enter here through glomerular filtration, and a little bit is gonna be secreted in the tubule. So if the patient have a decrease in glomerular filtration rate, this might not work for them, unlike LASIK, unlike loops, sorry. So the thiazide diuretic are weak diuretic because look where they act on the distal quantum tube, where only 5 to 10% of sodium could be reabsorbed. So that's why we use them in adjunct to other drugs. And they're going to block the pump NaCl, and this is going to cause a decrease in reabsorption of sodium. Sodium is going to go out with the potassium, with the water, with the chloride, and also you're going to have increase in calcium reabsorption. So this is different. Here you're going to have an increase in calcium reabsorption. The mechanism is kind of deep, and I'm not going to go into it, but that increase in calcium reabsorption, this is the reason why we're going to use them instead of hypocalcemia or osteoporosis. And because you're going to lose a lot of chloride and potassium, it can also give you a state of hypochloremic alkalosis. So be aware for that. So what is the treatment? We use them for hypertension. We use them more than the loop for hypertension, even though they are weak diuretics. But the fact that they decrease the SVR, we saw that the loop were mostly vasodilator. They would decrease your payload. But the thiazide decrease the SVR. They have a very complex mechanism of action, because when you give them chronically, they're going to activate your renin-angiotensin-aldosterone system and actually increasing your SVR. But for some reason, this drug they are going to decrease your SVR. The mechanism is very profound, and I am not going to talk about this. So I will just remember that they decrease the SVR, and this is why they are mostly used in hypertension. We're also going to give them in nephrogenic diabetics insipidus. Remember, in your diabetes insipidus, you are insufficient secretion of ADH when it's central, but when it's nephrogeny, you have your ADH, but your kidney doesn't just respond to your ADH, and you're losing a lot of fluid. So this can be paradoxal, because thiazide diuretics are also going to let you lose a lot of fluid, but for some reason they have been found to work in nephrogenic diabetes insipidus. So this is why we're giving them. And for the special consideration interaction, so with all this electrolyte imbalance, just like with the loop, you want to watch out with your neuromuscular blockers and the hypokalemia and your dose of neostigmine when you do your reversal. So just be aware. And also your hypokalemia, if you give them with digoxin, it's going to increase your digoxin toxicity. I did upload a video about digoxin toxicity and everything about digoxin. If you haven't watched it, I highly suggest that you watch that. And your hyponatremia, just like with the loop diuretic, is going to increase your lithium toxicity. So just watch out for those interactions. And also, like with the loop diuretic, the NSAID is going to decrease the effectiveness, because the NSAID block the secretion of prostaglandin, and prostaglandin is natriuretic and vasodilator. You're going to lose those effects. So we can give them in adjunct with loop diuretic and other drug to decrease the blood pressure. They mostly act on the SVR. Now with the stuff like hypokalemia and all that stuff, you want to make sure you are aware, like when you use them in adjunction with ARBs. Remember your ARBs and your ACE. I made a video about it. If you haven't watched it, I highly suggest that you watch that, because the ARB and ACE are going to act on your renin-angiotensin-aldosterone system. So aldosterone does what? It's going to retain the sodium and water along, and excrete your potassium. Those ARB and ACE, they're going to make sure that your potassium get in. So it's going to kind of balance your hypokalemia that you have here with the hyperkalemia that you have with the ARBs and ACE. So this is what I got for hydrochlorothiazide. It's mainly the same interaction like with the loop diuretic, but they just act on a different side of action, and they are less potent. Now we're going to talk about the last class, the potassium sparing. The potassium sparing are going to act here on the collecting duct. Potassium sparing. And we're going to have two classes in the potassium sparing. We're going to have the aldosterone receptor antagonist, And we're also gonna have the renal epithelial sodium channel blocker. I call them the renal. So aldosterone receptor antagonist and renal epithelium sodium blocker, they're gonna act on the same side, but they're gonna get into the side of action differently. The aldosterone receptor antagonists are gonna get here through the basolateral membrane, like the basolateral membrane here. This is how they're gonna get there. But the renal, they are gonna act directly on the sodium transport system. Now, the aldosterone receptor antagonists, their action is going to be depending on the amount of aldosterone circulating in your blood. So if you have Addison disease where you have less aldosterone, these are not going to be effective. And the renal, they're going to act dependent on the amount of sodium you have. Now watch this. On the collecting duct, you only have 2 or 3% of sodium that is normally reabsorbed. So they're gonna be very weak diuretic, and we're always gonna give them in adjunction with other diuretic like the thiazide. Now your receptor, your aldosterone receptor antagonists, like epleron and others, they are not just gonna act on your aldosterone receptor, but they also gonna act on other steroid, your sex hormone. They're gonna act on your progesterone and your androgen, and they're gonna be responsible of giving you gynecomastia and other stuff, and your breast tenderness in the woman and gynecomastia in men. So you want to watch out for this. But these diuretics, they are weak diuretics, and they are used when you have like increase of aldosterone in your system. You want to give them with an adjunction with diuretics that lower your potassium, because they're going to increase your potassium. So you want to give them with adjunction like with the thiazide or the loops. And what they're going to do, they're going to decrease the reabsorption of water, sodium, potassium, and increase the reabsorption of potassium. Now, this class, you really want to watch out for old people with that hyperkalemia as potential side effect. People with renal disease, you want to watch out. If you want to give your ARB or your ACE, because they also cause hyperkalemia, you also want to watch out. So these are weak drugs, but they have a lot of interaction when it comes to the potassium. And also the renal, you want to watch the same. They act on the same pathway, but they don't get there on the same pathway, and they are not dependent. These aldosterone receptor antagonists are dependent on your level of aldosterone, and the renal dependent on the level of sodium, and they are both weak diuretics. So this is what I got for diuresis. If you like this video, please subscribe, share, and click on the like button. If you have any suggestion, leave a comment below, and thank you, and I will see you on my next video.